Good evening, everyone. Today we are here again with another series of ACP India case files. And today we are very fortunate that Governor ACP India Chapter Dr. Anuj Maheshwari is also going to speak for the first time and as a guest on this show. And he will be talking about the EMR and the ACP early career physicians. Kushal, can you display the introductory slide of our governor, please? Let me just introduce you Dr. Anuj Maheshwari. Dr. Anuj Maheshwari is professor and head of the medicine at BVD University, Lucknow, and he is a very renowned PhD and DNB teacher for last many years and has almost all the fellowship which are looked after and sought after by anyone in the field of medicine, diabetes, endocrinology to his credit. He is the current vice president of RSSDI. Also, many orations and many awards to his credit. And under his guidance, able guidance, the ACP is growing leaps and bounds. I will request Dr. Anuj Maheshwari sir to please take over from here and just give a few words of wisdom to us.
Yeah, thank you, Amit, for the kind introduction. And I'm really not a guest today. I am still the host, and sometimes host has to play its role for its own members. So in the same way, I thought that I should take up today's topic by myself. And in fact, it was a request from Amit. Amit requested that today's topic should be taken by me. That's why, despite being at different place from where I am usually, I thought that it should be done. At least we should also do sometimes. So first, Dr. Daria will take up the case, I think so. And then I shall be taking up my lecture on EMR. Is it right?
Yes, sir. I will request you to introduce our moderator today.
Yes. So thank you. Before I hand over the dais to Dr. Prabhat Agrawal, who is the moderator today. Dr. Prabhat Agrawal is a very eminent personality of Agra. He is an eminent clinician of the Agra. He is professor in the Medical College of the Agra, SN Medical College, Agra. And recently he has done a very nice and very wonderfully organized conference, RSSDI is UP chapter. And it's a really a great one. And today's topic is also very unique. What Dr. Ashish Daria, who is a clinician from Jaipur, is going to present. This is the rare case of the good pasture syndrome, which is presenting by him as a very common presentations of the day-to-day clinic, and he found that patient of the good pasture syndrome. So we shall be knowing about the nitty-gritties of the case. After that, I shall be giving you few insights about the electronic medical record. Electronic medical record and electronic health record is a kind of the things which is least used in India. Multiple times people say that we are having a lot of patients, but still our data are not published because they are not so refined, they are not well kept. So I shall be telling you how we can start doing this from the early career physician stage of our clinical life. At the same time, I shall be also telling you how it can be useful if we want to make more publications, more research oriented, and what the ACP is keeping in its bag for our early career physicians regarding electronic medical record or electronic health records, and how can it really be more useful for that. But before that, we shall be listening to Dr. Daria. Now I am handing over the program to Dr. Prabhat Agrawal to take us from here.
Thank you, sir, for nice introduction of mine. So good evening, friends. Once again, we are here for a case that is a wonderful case which will be presented by our senior lieutenant member, Dr. S.S. Daria. He is from Jaipur. Basically, he is a diabetologist and very leading physician, renowned physician from the Jaipur. And today's case is almost, for the first case is a good pasture syndrome. We know it's a very uncommon disease, but in this case, it presents with a very common symptoms. So now I hand over session to Dr. Daria Saab. Please.
Thank you so much, Dr. Prabhat Agrawal, sir, for kind introduction. At the outset, I would like to thank Dr. Anuj Maheshwari, sir, Governor, ACP India Chapter, Dr. Amit Gupta, for giving me this opportunity to interact with you all. So I'll be presenting a case which is, I know it's a very rare case, but the symptoms presented were the very common. Sometimes we miss the diagnosis, but by giving this flow chart, I can say that we people can also diagnose the rare diseases also. Kaushal, will you present the slides, or I can share?
So you want me to share?
Okay, let me share. I'll do it. So am I visible?
Yes, sir. You are visible. Please make it in the slideshow mode, sir.
Okay. So a 24-year-old Hindu male.
Sorry to interrupt, sir. It's not in slideshow mode. As I told you, first you make it in the slideshow mode and select that one, sir.
No, it's already slideshow.
No, it's from you can see from your end only, sir.
It's visible?
Not yet, sir. You have to stop share screen.
Okay.
Kushal, you can present from there only, and Dr. Daria can speak from here. This can also
Yes,
be.
yes, sir. That I can do, sir.
Yeah.
I'll give you the control, the keyboard control, so you can click on the next.
Yes, you give me the keyboard control. It's okay now, visible?
Yes, it is visible. It is fine now.
Okay, sir. So there was a 24-year Hindu male presented with the chief complaints of red colored urine since 20 days, fever since 15 days, cough with hemoptysis since 10 days, generalized body swelling since 3 days, and decreased urine output since 2 days. Now the presenting illness, the red colored urine since 20 days, it was not associated with any drug history or pain abdomen or the burning micturition. The fever was insidious in onset, continuous low grade without chills and rigors. There was loss of appetite, fatigue and lethargy, but there was no symptoms of UTI, burning micturition, night sweats, headache and abdominal pain, vomiting, and it was relieved by the medications. Cough was also insidious in onset, that was progressive over the last 10 days, and it was not associated with any chest pain or breathlessness or the sputum production, but there was a coughing of bright red color blood. There was no postural or diurnal variation in the cough, and it was also relieved by the medications. The generalized swelling initially started as the facial puffiness, mainly the periorbital, and then involved all over the body, and it was painless. The decreased urine output was since only 2 days, which was insidious in onset. There was no history of any diarrhea, vomiting, or the pain abdomen or the burning micturition. In negative history, we ask about the LRTI symptoms: sore throat, nasal discharge, chest pain, palpitation, joint pain, high risk sexual behavior, jaundice, or the IV drug abuses. There was no similar past history, and there was no other comorbid conditions like the diabetes, hypertension, or the thyroid disorders. And there was no any major surgical intervention done in the past. In treatment history, he has taken the antipyretic or the cough suppressant occasionally in last 20 days, and symptoms were relieved. Regarding personal history, nothing significant except the history of red colored urine since 20 days. Sleep cycle was normal, appetite was decreased, and all non-smoker, non-alcoholic, vegetarian. Family history was not significant. In general examination, patient was conscious oriented. He was moderately built and well nourished. Vitals were okay. And the only thing, the blood pressure was raised. It was 160 by 100 mm of Hg in both arms in supine position, and temperature was 100 degree Fahrenheit. In head to toe examination, all were okay except the eyes. There was a pallor present. From head to toe, nothing special. Clubbing was absent. No cervical, axillary, inguinal lymphadenopathy. Oral cavity, tongue is normal. Yeah, pitting edema present was all over the body, but there was no neck swelling. On systemic examination in respiratory system, on inspection, the trachea was okay. Chest was elliptical, bilateral, symmetrical. The apical impulse was in left fifth intercostal space in mid-clavicular line, and the chest movements were equal on both sides. There was no supraclavicular hollowness, intercostal fullness, or indriving, and no use of accessory muscle. The palpation was okay with the inspection findings. The temperature, surface temperature was normal, no local tenderness. The only thing is that vocal firmitus was increased on the inframammary, infraaxillary, and the infrascapular areas. In percussion, the same findings which was in palpation, there was impaired note on percussion on the same inframammary, infraaxillary, and infrascapular scapular on the both sides. In auscultation, there was inspiratory, crackle, inflammatory, infraaxillary, or infrascapular areas on both sides. The vocal resonance was increased on the same all the areas which I already told you, and the normal vesicular breathing was present all over the lung fluid. In other systems, CVS was okay, normal. The abdominal and genitourinary system was okay. The CNS was all right. So the case summary. I'm sorry, this is I have to make. I think.
Hanji, Dr. Daria. So Dr. Prabhat is here to discuss it.
So now on this symptomatology, what is the physical diagnosis? The case summary, I am telling you that it was a 24-year-old non-smoker male with no significant past history presented with the cough with hemopsis, hematuria, low-grade fever, generalized body swelling, and the decreased urine output, which was developed over the last 20 days. And the same, if I'll talk in the medical language, the physical diagnosis, a 24-year-old febrile male with the hematuria, oliguria, cough with hemopsis, generalized edema, and lung field suggestive of consolidation in the bilateral lower lobe. So on the basis of history and physical findings, it seems to be a case of pulmonary or the renal syndrome. Now come to the differential diagnosis. The differential diagnosis, first I kept, it was, would be a case of tuberculosis with the, my slides are visible.
Sir, your slides are visible, but they are not in slideshow mode.
Okay, no issue. The tuberculosis with the UTI, sepsis, AKI, or the renal tuberculosis. In favor, there was a symptoms of cough, hemopsis, fever, or the hematuria, but the against points were there was no weight loss, expectorant consisting of the pure blood, and there was a bilateral basal finding and feature suggestive of there was no sepsis, no tachycardia, hypotension, or the high-grade fever. Next diagnosis, probable diagnosis may be a nephrolithiasis with the community acquired pneumonia. In favor, already the fever, cough, hemopsis, but the against was the painless hematuria. There was no abdominal pain or the burning micturition. Third possible diagnosis may be a community acquired pneumonia with the sepsis AKI. Already in favor, cough, hemopsis, hematuria, but the against thing was there was a long history of low-grade fever without any history of the URTI or the expectorant of the pure blood. There was no breathlessness, and there was no evidence which was suggestive of the organized or the lobar signs and symptoms of the sepsis or the pneumonia. Another probable diagnosis may be a post-streptococcal glomerulonephritis with the streptococcal pneumonia. But the points against is that there was no upper respiratory tract involved with the skin infection, and there was no high-grade fever expectorant of pure blood. Now come to the next probable diagnosis is the connective tissue disease, which may be either a systemic sclerosis or the SLE or the RA. But the against points were there, it was a very short history, no involvement of any musculoskeletal system or no any breathlessness. Now come to the rare disease, which may be on the basis of all the findings, it may be an anti-GBM disease. The only against point was because it is a rare disorder, so we think in the last. Another thing may be there systemic vasculitis, like another name is Wagner's granulomatosis. The same against features were the no nasal discharge, sinusitis, respiratory findings suggestive of any cavitary lesions. These all are the systemic vasculitis with different names, the HSP or the your Churg-Strauss syndrome or the microscopic polyangiitis. Another systemic vasculitis is cryoglobulinemia. There was no history of joint pain, no skin manifestation. So keeping all in mind, we went for the routine investigations. And there were in CBC, there was anemia, it was around 8 gram per deciliter. The PCV was 25.2. In biochemistry, the blood urea was raised, serum creatinine was also 4.04, but rest the LFT electrolyte were okay. The lipid profile was all right, calcium, phosphorus were all right. And 24-hour urinary protein, it was mildly raised, 2.42 gram in last 24 hours.
Sorry, sir, your slides are not moving.
Now moving.
Yeah, please.
So in urine, there was a occult blood present, leukocytosis was there, and the RBC was fulfilled, and WBC was 5 to 8. Then the X-ray, this is showing that there is a haziness in right lower zone. On the basis of clinical findings, we did a Hrct. ECG was showing the sinus tachycardia, and ultrasonography of abdomen was showing the bilateral bright kidney with the normal size. There was a mild ascites, mild bilateral pleural effusion. The other markers like HIV, HBs, anti-HCV were negative. So till now, on the basis of history, there was a cough, hemopsis, hematuria, or the oliguria edema. And on examination, there was a conjunctival pallor, generalized edema, consolidation in the lung. Anemia was there in the routine investigation. Deranged RFT and hematuria, proteinuria were there. And X-ray was showing the consolidation on bilateral lower zone. So rule out these, we did a special test for all the probable diagnoses: Hrct, chest, sputum, urinary tuberculosis for PCR, and the other upper respiratory tract examination. To rule out the vasculitis, we did a C-ANCA or biopsy or P-ANCA, and the peripheral blood film, upper respiratory tract examination, or the renal biopsy for the confirmed diagnosis. Till now, the sputum, or so these all are the investigation. Because of some technical glitch, it's not moving. Otherwise, it was an animation. So I'll skip this part because on the basis of all the things, we did the examinations. So now come to the examination part, Hrct. Here you can see there is a bilateral consolidation with a bilateral pleural effusion. Underlying collapse consolidation of lung parenchyma with infective with patchy areas of consolidation with the ground glass haziness in bilateral lower lobe. On upper respiratory or ENT examination, nasal endoscopy was okay, laryngoscopy, no tonsillitis or pharyngitis. The special investigations we did was anti-myeloperoxidase, which was negative, anti-proteinase, which was also negative, RA factor negative, CRP negative, but the anti-GBM was significantly raised. It was 100 RU per ml, and the positive was only 20. The C3, C4, urinary TB, PCR, all were negative. ANA, anti-dsDNA, Montauk's test, all were negative, and urine culture was done, which shows no organism in that, and sputum gram stain or the KOH were negative. AFB was also negative. ASLO, BT, CT, APTT, all were within normal limits. So we wait for the renal biopsy. This renal biopsy on microscopy or the examination, it shows there was a crescentic glomerulonephritis featuring crescents over 26 by 34 of sampled glomeruli, or the acute tubular multifocal interstitial inflammation comprising of lymphocytes, plasma cells, neutrophils, and mild increase in the tubointerstitial chronicity was observed. So after this, the renal biopsy shows crescentic glomerulonephritis in view of seropositivity of your anti-GBM antibody, the differential diagnosis and the clinical features suggestive of the anti-GBM disease. So now one by one, we rule out all the things that pulmonary tuberculosis with sepsis, because there was no sputum, the community acquired sputum was gram stain was no organism, microscopic P ANCA was negative, Wagner's for C ANCA was negative, for Churg-Strauss there was no peripheral eosinophilia, biopsy not suggestive, and there was normal IgE and the TEC. For post-streptococcal glomerulonephritis, their ASLO titer was normal, upper respiratory rate was normal, and the complement level was also normal. HSP was also ruled out because there was no skin manifestation or the complement level were normal. The anti-GBM or the good posture syndrome, yes, because of your renal biopsy highly suggestive, and the anti-GBM positivity proves the diagnosis of anti-GBM. All cryoglobulinemia, nephrolithiasis, connective tissue were ruled out by the their particular investigations. So till now, with the history, cough, hemopsis, fever, hematuria, or the examination, conjunctival pallor, anasarca, or the biochemistry, or the X-ray, HRCT, the immunological or the renal biopsy, summarizing the positive findings in favor of the anti-GBM or the good posture syndrome. So our final diagnosis was a good posture syndrome, and we started him on prednisolone 60 mg 1 mg per kg per day, and then patient was discharged and advised to follow up in the every 2 weeks. So this was my case. If you people allow, then I can discuss the good posture, but I think it's okay because I have to present only the case.
Dr. Daria,
Yes, sir.
thank you for a wonderful case and a very scientific presentation. You did first differential diagnosis. That is very important, especially for our postgraduate or the early physicians.
Yeah, sir. This is basically for the early career physician. So how to rule out with the...
This is a basic and wonderful thing. What did you do?
Thank you so
Second,
much, sir.
you also did a relevant investigation, and also after investigation, you all rule out all the again differential diagnosis. So this is a wonderful presentation. We have presentation, and we all should learn the way by which you present. Though it's a rare case, but in a year we can see 1 or 2 cases in a year. So we should know. We should always keep in our mind. Rare diseases sometimes can be seen. It may be your hard luck or good luck that you can see case sometimes once in a case. And I still remember during residency, 3 consecutive months, I saw 3 cases of the good posture. Though it was rare, but it was my hard luck, or you can say good luck. At that time, I used to that it is a rare, but I start thinking that it is a common cause of the hematuria. So one of my teacher once scolded me, it is not a very common. You always think of any hematuria, you always start thinking of the GBM, anti-GBM. So this is a wonderful case. If any questions, any queries from any resident or the physician, I think.
Thank you so much, sir, for your insight. This is my take-home message to all my early career physician friends or the residents, that it is essential to rule out the common cause of any pathology, because the rare presentation of common disease are more common than the common presentation of the rare diseases.
Definitely, sir, definitely. So
Thank
with
you so
this,
Yes, I agree, Dr. Daria. Rare presentations of the common disease is more commonly seen. And we also see, and in fact, we should always keep our mind open for any kind of the diagnosis which may come up. Many of the times we always say to our students that you should not think about the rare to rarest diagnosis. Of course, first we should always think the common things, but sometimes it happens that rare to rarest come in the flavor or in the cover of the common things. So that should always be kept in the mind.
Thank you, Dr. Daria. That reminded me of one of the proverb that was written in our PSM book, that your eyes doesn't see what your mind doesn't know. So though the presentation is very uncommon, but still it should be in our mind, and so that sometimes when we are not getting the right diagnosis, it is important to remember everything so that at least our mind knows. Only then we will be able to see. So you have made a very good presentation. I think our audience would have benefited from that.
Thank you so much, sir. Thank you so much.
So now,
Congratulations, Dr. Daria, for the nice presentation.
Thank you, sir. Thank you so much.
now I request to our second talk by our learned governor, Professor Dr. Anuj Maheshwari. He will going to deliver on the EMR for early career physicians. So I invite Professor Anuj Maheshwari, sir.
Thank you, Prabhat, for the kind introduction. I think all of you can see my screen.
Yes, sir.
Is it?
Yes, sir.
So we shall be talking about the role of EMR in good clinical practice. Obviously, today program is mainly for the early career physicians, so we can say that EMR for ECPs. But actually, the EMR is a thing which can be good for everyone, whether he is early career physician or he is in the late phase of his clinical practice. So let's talk about the role of EMR in good clinical practice. So before we explore the role of EMR in good clinical practice, 2-3 things should be very much clear to us. What does it mean, EMR? And what is the good clinical practice? How will you define the good clinical practice? And how will you understand or define the EMR? EMR is also called by few people as EHR. EMR stands for Electronic Medical Record. EHR stands for Electronic Health Record. Both are the same things, but we must understand the power of data before we discuss the EMR. Nowadays, somebody has said, some learned person has said that data is the money. So today's data is the money. But unfortunately, many of our Indian clinicians keep this money without being used anywhere. That is also very much unfortunate. Data can give you lot of scope of earning. Data can give you lot of scope of helping the people of your country. You can also find the disease management strategies while going through those data. You can also find the practicing trend. You can also find the trends of the prescriptions in the physicians, among the physicians. Lot of things can be done with the usage of data. So data is actually the new soil, and it is actually the fertile soil which can make a person winner in this age of economy. So that's why this data should always be respected. And as always, any good things may be having its bad effects. So whenever you are having a lot of money, it is always said that you should do its use in good work. You should try to help the people. You should do its use in the works of the social services, and so that the people can be happy. The same thing is for the data. Data is a kind of the money which should be used for the help of our countrymen, for the people, those who are really looking for the new guidelines, new strategies, and new recommendations for their treatment. And it is really very much helpful for the coming generations of the physicians. But how shall we be paving the way for the coming generation of the physicians until unless the present generation of the clinicians will not keep these data in their storage? So that is the power of the data, which I tried to explain you in a very nutshell. So today's agenda shall remain there. What is the EMR? Why should we use EMR? And why we should use it now? What can be the features of a good EMR? We are trying to summarize in the ABCD. Features of a good clinical practice. Again, we shall be trying to summarize that in the ABCD. And finally, conclusion. So as I already said, that EMR is a digital version of our prescriptions. EMR is a digital version of our paper charts, records for the patient, what we used to do in our day-to-day clinical practice by using our pen. Comprehensive documentation of a patient's medical history, test, diagnosis, and treatment at one point of the time is very much important. And many of the times it gives you a detailed analysis of the patient when he comes to the follow-up. Of course, it gives you a accurate clinical practice. It makes the clinical practice hassle-free and also keep you safe legally. I just like to share one of my clinical experience. When a patient comes to you second time or third time, many of the times it happens if the person is coming after 1 month or 3 months, because in chronic diseases, usually we do not call our patients very frequently. So when he is coming after 1 month or 2 months, we most of the time forget what was the complaint when he came for the first time. We only go through the reports of the patient. All the reports are good. Glucose level is good, blood pressure is good, pulse is good, all the tests are good. We tell the patient that everything is fine. And very interesting to tell you, many of the time patient also forgets what the problem he was having when 3 months or 4 months back he has come. And when you start saying that your everything is good, your report is good, your blood pressure is good, your pulse is good, your temperature is good, then patient start thinking, why did I come to the doctor when everything is good, when I am completely healthy? Unnecessary, I am wasting my time and money before the doctor. But once you are having an EMR or electronic medical records, you can ask your patient, last time 3 months before you were having body ache, what about now? Last time you were having coughing, last time you were having little breathlessness, what is the position now? Then patient understands how much I have been better now. Then he starts realizing what the miracle has been done with the treatment. And then he understands the real worth of his treatment for which he is paying money, for which he is giving the time and taking the treatment. So now the question arises, why should a doctor use the EMR? One is for safe and secure record keeping. Why this secure record keeping is necessary, I just tried to explain you in just previous slides. It can be comprehensive and time saving. It can be it can give you a big picture in a small span of the time, that you can know about 1 year old history about the patient. And I really tell you, patient appreciates it very much when you ask him, एक साल पहले आपको ये problem थी, what is the position now? How are you now? Do you still have? Patient thinks that doctor is so pertinent and so much caring for me that he remembers that 1 year before I was having this and he is asking for that. And this really makes a very good emotional connection from your patient of you. And of course, the easy access of the data improves the working efficiency. This is a thing which is to be proven by doing so. It's not a thing which can only be realized by telling you this. EMR improves the clinical revenue and high revisit rates. I really told you just now that why did it increase the better follow-up? Because you are knowing better your patient. Your patient is having a very good opinion about you. He thinks that you are giving a very personalized care to him, remembering each and everything about him. And this actually turns into the revenue when he goes out and tells that this doctor is very much caring. And apart from this, another way of the revenue is this: when you are putting up your data into the analysis. The advanced analysis of the data not only helps to improve the quality of the life, but also it improves the quality of the treatment. It increases the level of research. It increases the level of publications which are being done. In my previous of some presentation, I have shown that India is a country which is having a lot of patients, lot of population. We are the country having the most dense population. We are the third largest population of the country, and we are also having so many diseases, but our data keeping is so poor that we do not make the guidelines for the benefit of our patient. We do not analyze the data of our own patient so that they can be helpful for our own clinical practice. We are still bound to follow the guidelines which are being based on the data which is being taken from the Western population. EMR opens the opportunities for clinical trials and leading CMEs also. We have tried to explain it, we have tried to show this, to witness this by ACP platform putting up the COVID diabetes study, in which we tried to collect data from multiple corners of the country using the platform, and which actually summed up into a publication. Apart from that, in the same manner, we have also tried to do the collection of the data for the May measurement month studies for the hypertension also. Apart from this, still number of things are waiting, which can be used in the near future for using these EMR platforms for clinical trials, which can be converted into the leading CMEs after getting them analyzed. In the COVID times, that EMR has really made the healthcare more useful and more accessible, more approachable for many of the patients as well as clinicians. It was a time when clinicians were not really feeling safe to come out before the patient. Patients were also not willing to come out from their home. Many of the patients were having the symptoms of the COVID. Doctors were and other healthcare staff were also scared of coming before the patient. It was the EMR which has helped the people, those who are working into the healthcare services, by increasing focus on standardization. It was the new technology which has really worked well, not only for caring good patient care, but also giving them a treatment sitting in their home. It was really a wonderful thing when I was sitting in my home and patient is sitting in his home, and both of us were talking to each other, and I was sending a written prescription to him on his WhatsApp or any SMS method on the phone. So many of the times we have seen such kind of the situation. There is new technology which is coming up, in which blockchain is performing the security of the data. Many of our clinicians, when I talk to people, they say that we are scared of our safety of the data. So for safety of the data, blockchain concept has been introduced, through which this data cannot be taken out, it cannot be theft. And apart from that, by using EMR is now adding up that new technologies in the treatment of the patient to reaching to the patient, and artificial intelligence is also becoming a part of this new development of the EMR through which the telemedicine is becoming more and more stronger. In fact, India is a country where doctor-patient ratio is very poor. In such kind of the situation, this is the need of the hour. COVID has given this boon to us to reach through this technology. Before that, telemedicine was not allowed in India to be used. COVID has given this opportunity to make the telemedicine more and more popular. And this is a thing through which a small number of the doctors can reach to the big number of the population which is needing them. 5G networks and their increased device loads are also giving the EMR new strength. Wearables will boost patients' health engagement. So let's talk about the ABCD of the good EMR, what I was telling initially. The ABCD of the good EMR is the access. B stands for the brisk. C stands for the communication, and D stands for the decision support. Access to the data, access to the patient, patient's access to the doctor is being facilitated by a good quality of the EMR. It makes the prescription writing very fast. That's why it is called the brisk. It makes the treatment very fast. Many of the times it may happen that a person is having a chest pain, a doctor is sitting in his home. And if the patient comes to the hospital, it will be requiring at least 1 hour. But a doctor who is sitting in the home and patient is sitting in his own home, and doctor just suggested take a half tablet of the aspirin, put under your tongue, and sometimes that patient gets some relief. And this is the miracle of the brisk EMR practice. It gives good communication. I think everyone will agree that communication improves. Doctor-patient relations are also becoming better by using the EMR. When you are knowing more to your patient, when you are knowing the comprehensive picture of the patient, when you are seeing a comprehensive picture of the patient at single screen, that time your patient understands that you are very much caring, you are really a learned doctor, and you also understand patients in toto. And that makes a better communication between patient and doctor. Of course, at the end, it helps in the decision taking for the treatment, and it supports in the taking decision. So if we talk about the access for patients, clinicians, at the same time, data safety, all the three things, access becomes better, which I have already explained in detail. As far as the access for patient is concerned, patients have easy access to their records. There has also been certain applications which can be downloaded in your computer as well as in your phone, through which patient can also access what you have already seen on your computer. So doctor and patient both can access to their health record. Ayushman Bharat Health Account has already been developed, and this is creating India's digital health ecosystem, through which everyone will be having a digital number of the healthcare, and whenever anybody would like to see about its previous records of the health, he can put that number on the screen and one can see whole record of the patient. With the upcoming Ayushman Bharat Health Account, patient will be able to manage their own data, and doctors will be able to follow longitudinal care across different healthcare organizations. So many times when doctors comes to the when patient comes to the doctor and very little time is there, and sometimes because of the atmosphere, he fails to tell each and everything, whatever he wants to tell. Sometimes he forgets so many things. This kind of the accessibility will make these things more easier. When we talk about the access for the clinician, obviously we understand this better. Doctors will be able to access all their data from any device because of the cloud-based infrastructure of all EMR, which is a prerequisite based on the Ayushman Bharat health records. Physical consult or video consult from anywhere can be a good thing for the clinician. Telemedicine rules which have been made by the government India, this says that first consultation should be video consultation, or if you are consulting to your doctor for any new problem which has not been consulted before, it should always be with the video consultation. You should have all record at your fingertips, and those records can only be kept on the fingertips if you are using a good quality of the electronic medical record system. When we talk about the data safety, as I already said, that many of our clinician friends are very much afraid of their data safety. They are really worried about that somebody may not take away their data and may not be used for some unsolicited purpose. Standard data encryption keeps your data safe at all times. You can read the electronic health record form through your vendor contracts, and these contracts should be signed very carefully. Always sign a contract whenever you are purchasing any electronic health record system or electronic medical record system. And don't forget to see it is having a clause that your data will not be accessible without your permission for any reason until unless it is not required to the statutory reason, means asked by the court, asked by the law of the land, or by police information. It cannot be used, it cannot be accessible, it cannot be seen by anyone without your permission. When we talk about the brisk or fastness of the good EMR, this is the fast and energetic advancement to your practice. Both EMR and the clinician go hand in hand. Optimally utilize the vigor of electronic medical record, the clinician must gear up and become the brisk too. Many of the times people say that it is really very tedious to fill all the records in the EMR and it takes a lot of time. But believe me, once you will start doing, you will start enjoying this electronic medical record system, because you will be having all the data at once before your eyes, which will help you in taking good decision for your patient. Smart recommendations can come out with the brisk. Another evidence of the brisk working or fast working through the EMR is that you don't write to full spelling of anything, whatever you want to write in your data sheet or in your prescription. You just write first 2 or 3 words, your rest of the words will automatically appear there, and they will give you like that. You can see it here. If you want to write the diabetes mellitus, you write diab only. All the diabetes mellitus related things will appear, and you can select anyone, whatever you want to write, and as and when you will select, it will start appearing in the appropriate place where it should be. And this gives you faster record keeping. ECP is faster typing than writing already. So many of the times we do long writing in our prescription. Sometimes it is legible, sometimes it may not be readable, sometimes it is it is so long that it makes our writing so bad that it's very difficult to understand by anyone who is seeing the patient. EMR is actually the solution for all these problems. So even for the old timers, the smart recommendation make the data capture faster and easier by using the EMR. It makes the practice management also brisk, means fast. Easily you can manage your patient with additional electronic health record features. Every day we are adding up with the new advancement of our existing electronic health record system. You can track your data and be up to date. For last 3 years, I have got changed in my EMR so many times as per my need. So whenever you are using this, new needs will arrive, And when new needs will arrive, probably you will ask your service provider to do those changes which you are really looking for your day-to-day practice. It also helps in making the presentations or PPTs for your talk also. Sometimes you can also make a very good communication using your good EMR. You can get very good data for any disease. You can get very good amount of the information from your EMR, and you can convert that into the PowerPoint presentations to present in some case discussion or in some of the conference. So effective communication between teleconsultation for virtual consult, which has already been discussed, you can do making this better communication, teleconsultation, sitting a patient in a remote area or remote village. You are sitting in the tertiary care center at the metro city, and you are both are connected with the help of the EMR. SMS and WhatsApp integration can give the accessibility to the prescription what you are writing here sitting in the tertiary care center, which can reach to your patient directly who is sitting in the remote area. You can review the patient clinical summary and private notes very quickly. So good doctor-patient communication, which means the improved healthcare outcome, high patient satisfaction, high patient retention, high referrals and revisits, low chances of the malpractice, and low litigation rates. It all can be achieved by using a good quality of the EMR. By prompt messaging, you can communicate with your healthcare provider, and healthcare provider communicate better to the patient or patient relatives by using the technological advancement in present communication devices. Patient Connect module for empathetic or meaningful messaging with appropriate context while using the WhatsApp and SMS services. Virtual clinic has been experienced in the COVID times highly successful, which were safe and successful in easily communicating with the patient sitting anywhere. With single patient summary and longitudinal analytics were there before you go to the next patient. And while seeing your patient, you are listening final word from him or giving the prescription to him. In the meantime, you can also start seeing the analysis of the reports of your next patient also. And very nice thing it was in the COVID times when I have given the consultation sitting in Lucknow to the patient who were sitting in the Bangalore or in the Chennai or in other parts of the country. Communicate your clinical experience with your peers, with your colleagues, and good EMR, especially what the EMR we are going to give our early career physicians, is having this much of the features which can give you a statistical analysis about your day-to-day clinical data, about your day-to-day clinical practice, what you are facing in our or in your day-to-day clinical life. You can review easily the data, you can make them into the graphics, you can change them into the graphics, you can download those graphics, you can present those graphics in the form of the PowerPoint presentation, and finally make the presentation for the conference or the meeting in which you can share your experiences with your colleague. So features of a good EMR is another one, that is a decision support. A strong clinical decision support system in the form of the advanced comprehensive analytics, extensive record keeping with easy retrieval. It is in a smart tool and calculators to save time, useful triggers and alerts for the conditions or values, handy and customized menus or predicted entries for varieties of the patients which may be requiring different kind of the care. You can ensure through a good EMR. You can help the medical fraternity making better decisions by Using Good EMR, you can easily publish your original research. You can help the fraternity in making good clinical guidelines based on the data which are with you, and multiple clinicians can collect their data at one place to give a better picture of the geographical area in which they are working. You can ask original questions from your data, like you can get the answers to clinical questions to your own practice benefit. You can also think that how many patients of your clinics could reach to the 7 HbA1c in 1 year. How much percentage of the patient could reach to the HbA1c 6.5 in 1 year of the practice? How many patients did not turn up again after coming for the first time? You can plan prospective research studies, or you can perform those studies while using the Good EMR. You can also have a retrospective reviews and retrospective analysis of your own data while working on the EMR. Always follow the good clinical practice guidelines and follow the standard research framework and protocol while using these data system or support system. Let's talk about what is good clinical practice. What is the ABCD of the good clinical practice? Availability stands for A. B stands for the behavior. C stands for the competence, and D stands for the data. Availability of the clinician, availability of the healthcare facilities, availability of the system is very much required round the clock 24/7. As far as the behavior is concerned, which is very much important in the Indian perspective, many of the times we see that people are quite outrageous because of the behavior. Competence, obviously, which is the thing which everyone look for, and finally the data. So when we talk about the availability, be available for patients in multiple ways along with clinic. If you are not at the clinic, this EMR allows you to be available on the teleconsultation, be available on the SMS, WhatsApp integration, and of course, some of the applications are there which can make a doctor available to its patient. As far as the teleconsultation is concerned, you can connect with patient with audio or video call, record your calls and capture data on the go, and share the bills and prescriptions digitally, increase your reach and referral to more and more people and clinicians. There are certain easy to use applications which can be downloaded to your systems, may it be mobile system or your computer system. They provide the harness and power of smartphones. Use the application to stay connected with patients and share notes and prescription at a single click. Improved care for quality doctor-patient relationship is a smart single patient summarization of the history and all relevant information at the time of the patient visit. Before seeing the patient, a quick glance can help recapitulate points and improve doctor preparedness and behavior along with patient confidence. All these points which are supposed to be available or supposed to be present for a good clinical practice can only be achieved while using a good electronic medical system record. It also helps in improving the behavior. Many of the time, some people is having myth in their mind that screen time affect the doctor-patient rapport. Sometimes some people say that when you are looking over to the screen, probably you are not looking in the eyes of your patient, and probably your patient one-to-one interaction is not so good. But as I already explained you with the example, it is not actually true. In the digital era, all patients in all areas of the country appreciate digitalization. And when you write prescription through your computer, patient always makes it appreciative, and patient do not mind waiting for a few more minutes if they are reassured and informed about the critical importance of their longitudinal data in their well-being. It makes you more competent. You can gain the edge with advanced practice. High level of the data security with extensive patient detail is applicable for the good clinical practice, which can be ensured only by the EMR. because that kind of the security of the patient record can never be ensured when you are writing with your pen or you are keeping the data in your clinic physically. Possibility of the longitudinal analytics on elaborate data is also another feature what you can use, because when you are trying to use your collected data or your data which you are kept physically in your clinics in the form of the case sheet or in the file, probably you will be requiring another manpower to convert it into the electronic system. But once you are taking all the data already in the electronic system, it will take only a few minutes or seconds to convert it into the statistical analysis. So how easy it makes your life and research as well as analysis, what you really wish to do for the publications and improving your profile. Analytical dashboard availability is there for all patients in most of the EMR. Handy population, which summarizes and metrics within the electronic health record, is another important thing and good thing what you can achieve. The risk score system can also be used through the EMR. You can put up the risk score system there and ask the EMR to give the level of the risk of the patient who are having certain kind of the diseases. You can also predict the treatment outcome by using those risk score. So you know that once you write through your pen, it's sometimes very rarely not readable. In such situation, the competence gets affected. Digital prescription gives you the benefit of this not having very good handwriting. Digital prescription makes you more readable, better understandable, better legible. Use templates and review consult options for easily generating a prescription. Every EMR is having certain types of the templates which are ready-made. You can also make the templates in your EMR. For example, if you want to write that every patient should do 45 minutes exercise every day, you can make a template for that. Of course, if you want to give the rest to your patient, you don't have to use that 45 minutes exercise every day. You can make another template for the patient whom you want to ask complete bed rest. And you just click over those templates and those templates will automatically be scripted on your prescription. Writing the same medications might take 3 times the time for a digital prescription. Prevent prescription and dosage error can only be achieved through using the EMR, because many of the times it is not to be written by hand. Once you enter the medication, it suggests you whether it is to be given twice a day doses or thrice a day doses, and you can choose the option of that, and you can also give the instructions in the language what the patient understands. Sometimes it's not necessary every time you have to write the instruction of the patient in the English only. When we are writing the prescription by hand, mostly those instructions remains in the English. But once you are using the EMR, you can write those instructions which is to be understood by the patient, not only in English, but also in Hindi, Bengali, Tamil, Kannada, any language you want to write it. Be ready for any legal issues because you can easily showcase your record. Sometimes once you are writing the prescription by your hand, sometimes you may not be very much careful writing everything, and you may not be keeping the record with you. If somebody is putting up you in some legal issues or in some court sitting, then in those conditions, court may ask you something to prove your innocence. If you are using the EMR, probably it is very easy for you to produce evidences in your favor. So digital prescription is always a good option for that. It gives you an opportunity to review the patient history, use single patient summary view just before seeing your patient, and make better and informed clinical decision based on the real-time data. So finally, the last thing of the good clinical practice is D, that is D stands for the data. Safe, secure, exportable, analyzable, available, handy, shareable, and interoperable. If these properties of the data are there, then this can be always standardized, comprehensive data. Will safe and secure stands for more data is kept safe. It is not lost. It is not getting corrupt. It is not keeping into the old hard drives where it cannot be retrieved. It cannot be exposed to the data theft. Ayushman Bharat Health Account, blockchain, advanced data cloud computing and encryption make your data more safer on the cloud than in your on-site server or in your computer. So keep your data at on cloud instead of putting up on your own server or computer, because chances of getting corrupt are much more there as compared to the if it is kept at the cloud, may it be with the ABHA or it is maybe blockchain or any advanced data cloud computing system. It should always be handy and available if it is kept at the right time, right place, right form, and it will also be available to you when you are really needing at the right time, right place, and right form. Claiming to have lots of data which is unusable is much worse than not having any data at all. Focus on electronic health records that help you in meaningful use of your clinical notes and records. When we talk about the exportable and analyzable data, it makes better clinical decision at the point of care, but real utilization of the data can happen only when it can be exported anonymously as per standard regulatory norms when needed. If you are unable to analyze your data, it is like sitting in the middle of an ocean without a single drop of water to drink. So always remember, if you are keeping the data, it should always be available to be analyzed. And once it is analyzed, then only it can be exported to the system. It can be shared with the others. It can also be interoperable. The main focus of the Ayushman Bharat Health Records is interoperability, which is the beauty of this system. Very soon, regular usage of the electronic health records will become mandatory to allow for patient data to flow seamlessly between different providers across the country. And for that reason, I always say that multiple geographical areas may have the studies in their areas, and later on they all can be combined together. Here data can be kept at one place to make a countrywide analysis. With government guidelines, data sharing will be necessity rather than a facility. Thank you very much for your kind listening. If any question.
Thank you, sir. It was a wonderful, exhaustive lecture delivered on the EMR, and I know the simplicity and the uses of the EMR as right now I'm using for the last 3 and 4 years. So I can proudly say each and every word which is delivered by you is true. As we know, many times of patient used to fail to bring their old prescription. So this sometimes many of the times it helps us. Also, we can use the data as we did in the study which was supported or created by you for the diabetic and under the banner of the ACP. It was only possible just because of this EMR. So, is there any questions from the audience?
Many times it also happens, patient brings the prescription of 1 year before or 2 years before. And you are many times amazed to see, why did you retain this prescription? This patient should have been written this. And once you open the EMR, then you say, last time you have been prescribed insulin, but your prescription is showing the oral medication. Then he says, yes, doctor, I have lost that prescription. So many times you are getting getting facilitated to take the right decision. Yes. Many of the times for one reason or another reason, patient also is scared of using certain kind of the medication, or he tries to guide you as per his wish, but you are there to decide what is good for your patient, and you can do it with the help of the EMR if you are knowing the history of your patient very well preserved in the EMR.
So I think session is now over to the Amit Gupta.
Thank you, sir. Kushal, is there any question? If there is any question in the chat box, we can ask her.
No, sir. As of now, there are no questions.
Okay. Sir, I would just like you request you to make the announcement of the recent ACP collaboration with one of the,
Yes.
and what is the benefit of that and how somebody can avail that, sir?
Yes, in fact, we have organized this EMR talk for the reason that ACP has recently worked hard to endorse a system of electronic medical record. And that endorsement has been done by our ACP headquarters, which is by the people, those who are sitting in the Philadelphia and US. And that system has been approved for the use of ACP members in India. And that is Indian system. It is not a system which is being given by them and asking us to use that. We have requested that to be endorsed. That company we wanted to be endorsed had requested, and that has proposed ACP to give this system for 3 years free of cost to all early career physicians. For all early career physicians can use this system free of cost for the 3 years, and after that they will be charged only 50% of the price or 25%. I don't remember exactly what is written in the contract, but very nominal amount of the EMR fees, which is chargeable to the other people, those who are not members of American College of Physicians. So this is a good thing for all American College of Physicians members. You can use this platform, and very soon we shall be sending the link to join this platform to all ACP members. All ACP members, those especially those who are the early career physicians, they can use this facility for the next 3 years without thinking anything to pay, without any price, and this will also help them in making them more digitally correct, more data savvy, and as well as they can also be putting up their own clinics performance in their own screen. And apart from that, in near future, we are also going to start many new research activities from the American College of Physicians, many activities which will be in terms of collecting the data, collecting already existing data. So people, those who will be using this platform, they will be easily able to participate in those activities which will be coming up in near future, maybe in the next few months, or maybe every year. We want that 2-3 such kind of the project should keep on running. By doing so, the member of American College of Physicians will get a chance to see their name in various publications, in various papers which will be published in Indian and journals abroad. And they have to do only one thing, just keep all the records safe. And this can only be done by using the electronic medical record. And this system is being provided to them free of cost, without any price, paying any price. Neither you have to take any obligation from any support system or any industry person, or neither you have to be you may be having this kind of the thing that your data is being seen by someone else. Whatever you are writing is being visible to someone else. Here you are safe from all such kind of the negativity, and that is the best part of this, for which we try to do that.
Thank you, sir. And I must appreciate your efforts, and because of your efforts, now we have such a big opportunity to us. And we have more than 3,000, almost 3,000 ACP members, and many of them are early career physicians. And this will definitely help them. And I will request Dr. Prabhat, Dr. Daria to spread this word to their contacts, so that more and more ECPs, they learn about the recent activity of the ACP and the EMR itself. And sir, I would like to thank Dr. Prabhat Agarwal for the excellent moderation, Dr. Sher Singh Daria for presenting an excellent case, which was a great learning experience for all of us. And finally, our governor, Dr. Anuj Maheshwari, who is always there to support any kind of activity. And we are very grateful to you for always guiding us and your blessings, sir. And with this, we would like to conclude this session with the permission of our governor, Dr. Anuj, sir.
Yes, Abid Gupta.
Yes.
You can.
Thank you, sir.
Thank you, sir. Thank you, everyone. Thank you. We will see you again in the next month, again with another interesting case and very useful topic. Thank you. Thank you, everyone.
Thank you.